Hello, good evening all. The greetings from Department of Anesthesia and the SO Medical College, Tirupati. I am Dr. SREENIVASARAO, Associate Professor of Anesthesia. So today I want to share some of the few points regarding the amniotic fluid embolism. Till now, the amniotic fluid embolism was using as a protective diagnosis. Whenever any maternal death occurs, whenever we don't have any explanations to explain the reason for the maternal death, blindly we are diagnosing as amniotic fluid embolism. That is one reason. Second thing is usually the amniotic fluid embolism is till now they are diagnosing a post-mortem only. So there are no investigative methods are there to diagnose the antemortem. That's why we are diagnosing the post-mortem only. That is the one reason why we are taking as a amniotic fluid embolism for unknown reason death of a pregnant patient. And second thing is that is the symptoms are anyway mysterious and diagnosis is mysterious and presentation is very severe. Patient will die very suddenly. Okay, so coming to the objectives of today's topic, we identify the risk factors and pathophysiology, signs and symptoms and management along with the incidence of fatality of the amniotic fluid embolism. So usually the amniotic fluid embolism occurs whenever the amniotic fluid enters into the maternal bloodstream. So it is a second leading cause of perimortem maternal death. Usually this is marked with a sudden cardiorespiratory collapse and a disseminated intravascular coagulation due to the consumption of coagulopathy, and often referred to as a anaphylactoid syndrome of pregnancy. So coming to the history, it was recognized by the mayor in 1926 and it was reported in 1941 by the Steiner and Lushbach officially named the disease as amniotic fluid embolism. So it was systematically described that the amniotic fluid embolism pathogenesis is the pulmonary mechanical embolism caused by the physical components in the amniotic fluid such as the meconium, mucus and sebum, amniotic cells. They will cause the obstruction and that causes the amniotic fluid embolism. Of that, in 1995, Clark et al. They studied a lot regarding amniotic embolism. They found that amniotic fluid embolism was similar to the anaphylaxis or a septic shock. Therefore, he proposed the name as AEF as a anaphylactoid syndrome of pregnancy. We can discuss how it was become as an anaphylactic syndrome of pregnancy in a future slides. Coming to the incidence, it ranges from 1.9 to 6.1 per 1 lakh births. And the United States, there is 2.2 to 7.7 per 1 lakh births, but contributing the 7.5% of maternal death. But in the developing countries, the mortality ranges from the 1.8 to 5.9 per 1 lakh birth. So don't surprise that mortality rate is low, because in developing countries reporting is very less. That's why the mortality rate is shown as a very less than compared to the developing countries. So case fatality, Fretty and all, they described that fatality is 24.8%, and Bersad et al. They reported that it is around 12.8%. The range is from the 4.7 to 24.3%. So in Germany, into 2011, they emerged as a primary cause of death during the population, and it accounts for the 24.3% of the maternal death in Japan. Okay, so normally there is no mixing of fetal cells and amniotic fluid cells in the maternal circulation, but some unfortunate rare cases or some many communication between occurs from the opening of the venous sinuses to the uterine venous. The amniotic fluid enter into the uterine veins and enter to the systemic cell and causes the amniotic fluid embolism. So what are the different risk factors for this amniotic fluid embolism? So older maternal age, multiparity, and after abdominal trauma, during abortion and amnio infusion, and placental abnormalities like placenta previa, placenta accreta, and placenta perfections, tears in the uterus and cervix, and the male baby, and IUD, the fetal death condition, and obesity also one more important risk factor, and eclampsia and preeclampsia also risk factor for the amniotic fluid embolism. And 66% of amniotic fluid embolism patients reported prior RLGs, aligning with the condition secondary as anaphylactic syndrome of pregnancy, exceeding general population setup rate. So additionally, 8% of the AEF associated with the IVF fertilizations, and it tenfold increase the risk whenever there is placental abnormalities like placenta accreta spectrum. So amniotic fluid embolism relating the cesarean section. So many earlier studies they concluded that cesarean delivery, particularly with a classic luteal section, raises the amniotic fluid embolism risk. But in 2023, the Ju they published by doing their study a population-based case cohort control study of 149 cases, 80% which are fatal. They reported that spontaneous vaginal delivery had a 12 times the risk of AIF than the cesarean delivery. And the instrumental vaginal delivery was almost 3 times risk of the cesarean delivery. They concluded that cesarean section is a protective for fetal amniotic fluid embolism. So previous what we are thinking, it is a misnomer. Coming to the pathophysiology of the amniotic fluid embolism, abnormal placentation, surgical trauma theory. So breaching of the barrier between the maternal bed and amniotic fluid, the amniotic fluid enters the system of circulation and it causes all the meconium, it will cause the pulmonary circulation obstruction, cause right heart failure, and followed by the amniotic fluid systemic circulation. Coming to the second theory, that activating of inflammatory mediators forming the cytokine storm by activating platelet activating factors, cytokines and bradykinin leukotriene thromboxane. And another, it's the increase in maternal plasma endothelium in AF. Is a endothelium is a powerful bronchoconstrictor and powerful coronary vasoconstrictor, and it is a procoagulant. That's why it causes a consumption of coagulopathy followed by the decay. So this is the entire scenario. What we see whenever the amniotic fluid enter the system, this pulmonary circulation, it causes the pulmonary hypertension, causes the cardiogenic, non-cardiogenic pulmonary edema, intrapulmonary shunt fraction will be increased from 2 to 28%, causes the bronchoconstriction, followed by the desaturation of the patient. The patient will present with the dyspnea and bronchospasm, cyanosis, and pulmonary edema. If hypoxia is severe, patient may develop the seizures, and this meconium, this causes decrease the coronary blood flow by the endothelium, decrease the coronary circulation, and decrease the ionotropism. This meconium, the factor present in the meconium, they cause a depression the myocardium causes a decrease of cardiac output. So whenever the right ventricular pressure increases, this interventricular septum is pushed to the left side. So cardiac output will be automatically decreased. That is one reason. Second thing is the contents present in the meconium that will depress the myocardium, that will cause a decreased cardiac output, followed by the pulmonary congestion, hypotension, and shock. If entered in the maternal circulation, thermoplastin release will occur, followed by the consumption of coagulopathy, disseminated intravascular coagulation, followed by the bleeding of the patient. This maternal hypoxia, it's leads to the fetal hypoxia, bradycardia, and fetal death. These are all the pathogenesis briefly. Now, amniotic fluid embolism. So Clark, he proposed the biphasic model of the pathogenesis of amniotic fluid embolism. He explains the hemodynamic abnormalities that occurs with amniotic fluid embolism, suggesting that acute pulmonary hypertension, vasospasm might be the initial hemodynamic response. So initial hemodynamic response is acute pulmonary hypertension due to the blockage or bronchoconstriction and vascular constriction by the inflammatory mediators that is called vasospasm. It might be the initial hemodynamic response that results the right side heart failure and accompanying hypoxia and account for the cause of sudden death or severe neurological impairment. This hypoxia causes severe neurological impairment. Those patients who survive the initial phase of pulmonary hypertension, which is very transient, they proceed to the next stage of left ventricular failure. So here, whenever the patient is a pulmonary hypertension, treatment is very easy. If you cross that stage, if the patient went to the left ventricular failure going, then the treatment may be more difficult. So left ventricular failure that causes hypoxia, the left force shift of the interventricular septum secondary to the right side heart failure that leads into the decreased cardiac output in the impaired coronary artery perfusion. And the direct myocardial depression of the amniotic fluid itself that decreases the cardiac output. The endothelium, which is an amniotic fluid embolism, is abundant, has been cited as a cause of left ventricular failure. So it is called as anaphylactic syndrome of pregnancy that is given by the Clark et al. So they suggested that AF is caused as an anaphylactic syndrome of reaction to the amniotic fluid and named the syndrome as anaphylactic syndrome of pregnancy. So antigenic potential can vary in individuals and therefore can lead to the different grades of the syndrome. For example, women carrying a male fetus are more likely to be affected than the female. So similarly, fluid containing a thick meconium may be more toxic than the clear amniotic fluid. So patients dying of amniotic fluid embolism have had a clear amniotic fluid. There is a shorter time for the initial presentation to cardiac arrest and increased risk of neurological damage or death in the presence of meconium or dead fetus. This suggests that under right circumstances, maternal exposure or even small amounts of amyloid food can initiate the syndrome. So confirming the theory, the anaphylactic reaction to the amyloid requires further research uses of the tryptase markers. So coagulopathy, again the Clark et al., they reported the 83% of the cases in national registry had either clinical or laboratory evidence of consumption of coagulopathy. The remaining 17% also died before the clotting status could be assessed by either by clinical or laboratory techniques. This amyloid food embolism is almost always associated with some form of dick, with or without clinically significant bleeding. This isolated disseminated intravascular coagulation causing the maternal hemorrhage may be the first indication of the problem in small number of patients. So this disseminated intravascular coagulation, this proved by the Harnett et al. They did one study, effect of varying concentration of amniotic fluid. That is, they took the 10 to 60 microliters of amniotic fluid and added to the 330 microliter of whole blood. They examined on the thromboelastograph, the thromboelastic variants, and found that amyloid fluid is pro-coagulant even with the 10 microliter study sample. So that 10 microliter of amyloid fluid also, it acts as a pro-coagulant as the consumption of coagulopathy, and it pushes the patient into the disseminated intravascular coagulation. So coming to the clinical presentation, usually the amyloid, this AEF occur during labor, after instrumental vaginal delivery or cesarean section, or even up to the 48 hours of post-delivery. Usually the patients will present with acute respiratory distress in 51%, hypotension in 27%, coagulopathy in 12%. This hypoxia causes the seizures in 10% and bronchospasm and uterine atony and fetal distress. So these are all the risk factors, different risk factors: vaginal delivery, multiple pregnancy, placenta previa, induction of labor, and more than 35. Below you can see the symptoms. There is a numbness, chest pain, vomiting, cough, and fetal bradycardia, intrauterus fetal death, and central nervous system seizures, and headache, loss of consciousness. And hematologically, the coagulopathy and cardiovascular, the patient with hypotension, cyanosis, and chest pain, and cardiopulmonary arrest and respiratory causes the symptoms like dyspnea and pulmonary edema and respiratory distress syndrome. So usually the patient will present rapid or abnormal heart rate with low blood pressure, hypotension with chills and vomiting, and severe anxiety along with a sudden shortness of breath and skin discoloration, amyloid embolism. So differential diagnosis is very important. Why? Because the diagnosis of amyloid food embolism is exclusion of the diagnosis. If you exclude the all other conditions, or if they fit into the all other risk factors, then only you can consider as amyloid food embolism. That's why differential diagnosis is very important. The pulmonary embolism, we have to differentiate. We have acute myocardial infarction and pericardial cardiomyopathy, anaphylaxis and aspiration and placental absorption and eclampsia and uterine rupture. But exclude all other reasons if you are diagnosed amyloid food embolism before diagnosing as the AEF. So, as discussed, diagnosed by the exclusion. This American Society of Maternal Fetal Medicine, they established objective clinical criteria of amyloid fluid embolism. They gave the 4 things. One is the sudden cardiopulmonary collapse, followed by hypotension, that is systolic less than 90 mm of Hg, and hypoxia, that is saturation less than 90%, along with a severe hemorrhage and dick. And symptomatology that will occur during labor or placental delivery. The absence of fever, other explanations of the observed findings. These 4 criteria, clinical criteria, we can diagnose amyloid food embolism broadly. The triad of AEF is hypoxia, hypotension, coagulopathy with a normal body temperature. So, in normal body temperature, we exclude the sepsis and any infective conditions here. If you go for fundal examination, it may detect the minute bubbles in the retinal artery sometimes, and high-pitched murmur of regurgitation, so indicate right heart failure, and full-blown dick is observed in 83% of patients. So it is an antepartum diagnosis, a mass and aspiration method. In the presence of central venous axis, blood from the pulmonary vascula should be collected using the method described by the Mason. He suggested to minimize the possibility of the maternal exogenous contamination. A more representative sample of the pulmonary vasculature can be obtained if blood is withdrawn of the distal lumen of a wedge pulmonary artery catheter. So after discarding the first 10 ml of blood, an additional 10 ml is withdrawn and it is heparinized and analyzed with the Papanicolaou method. So the presence of components of amniotic fluid, including the squamous cells and mucous strands, reinforces the diagnosis. This is particularly true if the squamous cells are coated with the neutrophils or accompanied by the fetal debris such as mucus hair. So a more reliable method of confirming the diagnosis might center on the identification of other amniotic fluid elements in the maternal pulmonary vasculature as opposed to the squamous cells. So other investigations, if you go for arterial blood gas investigations, ABGs, that increased pH and decreased PO2 and increased PCO2 and base excess is increased. So other samples of sent for CBC and platelets usually within the normal range. Thrombocytopenia is a rare finding, but in PT and APTT, the prothrombin time is prolonged because the clotting points are used up by the consumption of coagulopathy, and the values are institution specific, but intervention is indicated whenever the PT is 1.5 times of the control. APTT may be within a normal range or shortened. So in first, the fibrinogen levels are normal. After disease progresses, the fibrinogen levels will be decreased. So blood type and screening for anticipation requirement of transfusion is important. Chest radiography shows the heterogeneous and homogeneous areas of increased opacity, which are indistinguishable for acute pulmonary edema. Lung scans, some areas of reduced radioactivity in the lung field, and central venous pressure with initials, the raises the pulmonary hypertension, the CVP will be raised and profound drop by the severe hemorrhage. The 12-lead ECG shows the tachycardia, ST segment, and TVO changes, and findings consist of right ventricular strain pattern. So increased serum tryptase and urinary histamine concentration, significantly lower level of complement concentration suggests that it is an anaphylactic process. So tryptase is a serine protease with half-life of several hours. Although specific function of tryptase in anaphylaxis are known, but the half-life measured in hours instead of minutes of histamine, the protein has proven useful diagnosis anaphylaxis. Whenever the anaphylaxis is seen, in that condition, the tryptase levels will be raised and the histamine levels will be raised. And the complements, there is a C3, C4 complement levels has decreased. This shows the sensitivity of 88% and 100% C3 and C4 and specificity of 100%. And more studies also needed to determine the utility of both monoclonal TKH2 antibodies and zinc copper perforin. This monoclonal TKH2 antibodies and zinc copper perforin is a rapid diagnostic markers. If you take the blood and you can see that it is TKH2 antibodies and zinc copper perforin. There is a rapid diagnostic markers for amyloid fluid embolism. So few studies have evaluated diagnostic markers of serial signal T antigen. STN antigen is a fetal antigen present in the meconium amyloid fluid detected through the use of TKH2 monoclonal antibodies. So STN antigen is detected by using the TKH2 monoclonal antibodies. So TKH2 reacts with the meconium and mucin stains in the lung tissue in those of AEM. So serum levels are more than 50 units per ml of TKH2 monoclonal antibodies. The sensitivity varies between the 78 to 100% and specificity varies the 97 to 99%. So previously that is a postmortem diagnosis. Now the antepartum also will diagnose the amyloid fluid embolism by aspiration of the pulmonary blood and followed by the other diagnosis. And transthoracic echocardiography is very important investigation. It plays a crucial role in the diagnosis whenever that available. It is preferable if the patient is stability is achieved. You can use only whenever the patient is stable. So significant echocardiogram findings of AF include right ventricular dilatation, hypokinesis, and overload, and tricuspid regurgitation, right atrial enlargement you can find. So early stages, early cardiac thrombi may be identified with enlarged right ventricle and right atrium. So a characteristic feature of AF is bowing of the interventricular septum into the left ventricle, leading to the left ventricular obstruction, systolic function, resembling the shape of the letter T. That is the reason the RVO right ventricular right heart failure go into the left heart failure, pushing out the interventricular septum. So prevention high risk cases. So prevent the AF trauma to the uterus must be avoided during maneuvers such as insertion of a pressure catheter absorbed membranes, and incision of placenta during cesarean delivery should also be avoided, and avoid the tumultuous labor. And use whenever using oxytocin ducts which can precipitate excessive tetanic uterine contraction must be used appropriately and judiciously. They will prevent the AEM. So goals of management: early recognition and oxygenation, and resuscitation of hemodynamic stability, and to maintain the uterine tone, and correction of the DAC and delivery of the fetus. So Secure the airway if the patient is desaturated. Administer 100% oxygen with the positive pressure ventilation as early as possible. So you have to optimize the preload and reduce the pulmonary vascular resistance. And fluid association with the crystals colloids for hemodynamic instability, if you have to along with the judiciously monitoring the IV status and the arterial line transfer echocardiography to guide the fluid management. The vasopressors to maintain the mean arterial pressure more than 65 mm of Hg, and plan for the packet cell transfusion is ongoing in hemorrhage due to the urinatomy. Pharmacological management are vasopressors are and inotropic support should be there because the patients are hypotensive. So epinephrine is the first line of agent. So AF is anaphylactic. It works both for anaphylaxis and hypotension both. So Naridine, Dopamine are other choices. In the right heart failure, the milronine and levosimendan is considered. And steroids to reduce the inflammation and induce the amniotic fluid. And nitrotonic agent, when the atonic PPH is there, you can use nitrotonic agent like oxytocin, methergine, and carboplast to decrease the bleeding from the uterus. So treating the dick and blood products, we have used the 1:1:1 of platelets and FFP cryoprecipitate in a early resuscitation. And you have to monitor the platelet count and coagulation profile to guide the further transfusion. If the fibrosis level is less than 100 milligram deciliter, you have to administer cryoprecipitate. You know the each unit of cryoprecipitate raises the fibrosis in 10 milligrams per deciliter. And viscoelastic hemostatic assay to guide the transfusion of blood and blood products to monitor the coagulation profile. So still the bleeding is there, uterine PPH is there, uterine artery embolization sometimes helps. And finally, the hysterectomy may be required in those with the persistent uterine hemorrhage to control the blood loss. So treatment of the pulmonary hypertension. Pulmonary hypertension, right heart failure are the mainstay in AF, at least in the earlier stages. Now to administer load-reducing agents. And milrinone and levosimendan, they cause a pulmonary vascular dilatation, decrease the right ventricular afterload. And epoprostenol inhaled or intravenous access to reduce the pulmonary edema, pulmonary hypertension, and inhaled nitrous oxide, they cause the pulmonary vascular dilatation. So if the patients had a cardiac arrest, so it's very difficult to treat the patient with the cardiac arrest because already left ventricular failure will occur. If the patient recovers also, he will lapse with the other complications. So while doing the cardiopulmonary resuscitation, we have to see that left ventricular displacement is there. How to start the CPR? You see the CPR for 5 minutes. If there is no recovery within 5 minutes, you have to go for the perimortem cesarean section. So overview of management. For hypoxia, you have to give the 100% oxygen and positive pressure ventilation. And if the hypoxia is refractory, you have to take the help of ECMO. The patient is heart failure, you have to give the fluid resuscitation and vasopressors and inotropes and inodilators. Main goals of in heart failure is mean arterial pressure is more than 65 mm of Hg and cardiac index is more than 2 liters per minute and urine output is 0.5 ml per kg per hour and PaO2 by FiO2 ratio should be more than 250. If the patient is DAC, you have to give the massive transfusion, nitrotonic agent, and uterine embolization. If not recovered, finally you have to go for hysterectomy to control the bleeding. So novel approaches of this amniotic fluid embolism, exercise transfusion, extracorporeal membrane oxygenation, cardiopulmonary bypass, right ventricular assist device, and uterine artery embolization, and intra-aortic balloon pump to persist hypotension, cell salvage combined with the hemofiltration technique. These are all the novel approaches. So one word about the ECMO. ECMO has a proven successful when the patient is a refractory hypoxemia and a severe right ventricular failure. They are not responding to the medical management. It provides the respiratory and hemodynamic support that improves the right ventricular function. So anticoagulation-free ECMO can be considered if the ongoing hemorrhage is going on. Early decision making and transferring to facilities capable of ECMO improves the survival. So broadly, if you suspect the amniotic fluid embolism, these 3 scenarios you will find. So consider as intensivist, anesthesiologist, cardiologist, options is the multi-team approach. So if the patient is a cardiac arrest, what you have to do? You have to go for the high quality CPR, the first is circulation airway followed with the breathing, and manually displace uterus to the lateral tilt, lateral side or lateral tilt, and emergency delivery if the more than 23 weeks gestation, and activate the local or mobile ECMO team if it is a patient is not revived with a cardiac arrest immediately. Circulatory collapse, you will go for oxygen therapy and ventilation and vasopressors to maintain the mean arterial pressure 65 mmHg, avoid the fluid overload, and bedside echocardiography, inotropes and pulmonary vasodilators if needed, and consider the delivery based on the fetal age and maternal condition and available anesthetic support. The still circulatory collapse is there, the refractory hypotension is there, go for the ECMO. And aggressive coagulopathy and bleeding, so activate the massive transfusion protocol 1:1:1 and platelets and and tranexamic acid 1 gram over 10 minutes, and prophylaxis of treatment for uterine atony like oxytocin and methergine, and intrauterine balloon tamponades, and hysterectomy if the bleeding cannot be controlled. Consider thromboelastometry if available, and transfusion of blood products to keep the normal INR and APTT and fibrinolage level more than 1 gram per deciliter. So avoid the severe acidosis and severe hypothermia and hypocalcemia when out the patients. So coming to the prognosis, it ranges from the 11% to 26%. Deaths have been noted 1 to 12 hours after amniotic fluid embolism. The UK AEF registered reported 37% of the mortality rate, and early recognition and effective management of cardiac arrest significantly improves the survival rate. So if the patient survives of the amniotic fluid embolism also, they will suffer with a spectrum of significant complications, including the renal failure, cardiac failure, prolonged respiratory failure with ARDS, myocardial infarction, arrhythmias and cardiomyopathies, congestive heart failure, and left ventricular dysfunction, and prolonged coagulopathy and respiratory failure, and prolonged bronchospasm and liver failure, cardiogenic pulmonary edema, seizures and anoxic encephalopathy, and various cognitive and neurological impairments. So these are all the different complications patient develop for the long time. So these are all my references. Thank you.